team on this project as well. So just to let you know, this session will be recorded and it will be put up on the website. So before I go into the kind of key information, I just want to just get everyone to introduce themselves. So we've got Andrea Cronin, Dr. Josie Sood, and we will have Beauty Naomi later on as well. So Andrea, do you want to just introduce yourself?
Hello, yes, I'm Andrea Cronin. I'm the Cancer Commissioning Manager and I work for North East London CSU, and I support NEL, Integrated Care System, in the delivery of the cancer programme.
Thank you. And Dr. Sood?
Thanks, Harpreet. Hi, everyone. I'm Jyoti Sood. I'm a GP in Redbridge, but here with dual hats. One of the cancer leads for BHR, but also the NEL LD and autism lead. So welcome, everyone.
Thank you. So I'm just going to put some key information up. So can we just ensure that during the session, you all put yourself on mute throughout, especially when the speakers are presenting, to avoid any distractions or background noise. If you've got any questions, if you could pop them in the chat box, and what we'll do is we'll take questions at the end. This session will be recorded and made available on the website, and a copy of the slides will be sent out after the session. Also, just to mention that we've got Bola, who will be messaging some of you to ask you to confirm your names that you registered under. If you could make sure you keep an eye on your chat box to see if she's messaged you. If you haven't registered for this session and you want to get a certificate, then you will need to pop in the chat box your first name, surname, and your email address as well. So we're going to get started with Andrea. So I'm just going to put myself on mute. Just let me know when you want me to go to the next slide, yeah?
Right, so good afternoon, everybody. So thank you, Harpreet. Yes, next slide, please. So I just wanted to start off with the LEDA findings. So the LEDA findings are, this is the Learning and Disability Mortality Review, and the NHS long-term plan made a commitment to LEDA and to improve the health and well-being of people with learning disabilities. The review is to help support systems to understand what's going on in their area and then to deliver service improvement. And the LEDA findings found that 64 eligible patients reviewed, only 17% were recorded as having a cervical screen. For breast patients, 45 were eligible and 26% had a breast screen. And for bowel, we performed a little better with 46 patients who were reviewed and were eligible. 49% had completed their bowel screening kit. Next slide, please. So for the barriers, there's a number of barriers that the LEDA findings found. So lack of provision for reasonable adjustments, poor communication and lack of appropriate information, poor staff understanding and anxiety, and a lack of confidence for the person with a learning disability, and a lack of joint working relationships between the carer and providers. But one thing I think is quite significant is that pain and previous experience. So having a good first experience is really so important, and it may be better not necessarily to go ahead with a screen if the patient needs more time and they're scared and they're tense the first time they come for an appointment. But it can be an opportunity to have that teachable moment to explain what will happen, whether there's any sort of equipment that you might want to explain and how it's going to be used, and then booking a future extended appointment. And this helps the patient's readiness. So we need to make sure that we don't go ahead with something if we know it's going to be detrimental in the long run. Next slide, please. So what we want to achieve, we want to achieve a provider that delivers a service that's accessible, service users who feel confident and supported, service users and their carers are given the right information so that they're able to make an informed decision, and if that, hopefully that informed decision will be in the best interests of that patient to go ahead with the screen. And GPs who safety net those service users at their annual health check. So this is, again, it's another teachable moment. So it might be about explaining the importance of screening and ensuring there's an action plan within that annual health check to support that patient to participate in their screening, and also engaging with carers if that's appropriate. Next slide, please. So we know that the COVID-19 has compounded some of the delivery of screening, and that's for the general population as well as this particular population. But we must help and must ensure that we're, as health care providers, are making reasonable adjustments. And those reasonable adjustments can be easy read information, easy watch information videos, and preparing the service user for their invitation, outreach to service users, longer appointments, and anything that makes the service easier to access. And there are lots of resources. We are going to be touching on that. And I know Harpreet has pulled together a huge raft of information that has been sort of checked, if you like, for usability. So we will be touching on that later in the presentation. Next slide, please. So we have some of the data from North East London, so you can quickly look at your particular borough area, and the information can go down to each GP practice area and their PCN area. So if you need to get that granularity of information, please do contact the people in your CCG, your known contacts, who'll be able to provide you with that greater granularity. But we know, sort of working around BAL, the conversations that are happening at that annual health check are helping. We're not quite at the acceptable threshold of 52%, but we're some of the areas are up in the 40s, which is really promising. So next slide, please. So again, cervical breast cancer, rather, we're a bit on the low side here, and I think this is partly due to the pausing of the breast screening programme during COVID. So that has impacted detrimentally on our figures. But we know engaging just with one person with LD can have a big impact in increasing these percentages, because the numbers are so low. Next slide, please. Oh, I think we slipped on cervical screening. So cervical screening, again, I think the main message is, if we can engage just with a few more patients, it can make a big impact on those percentages. So just one or two patients, people with a learning disability, to come in for a cervical screen can suddenly shift the percentages for a borough area, and that's an important message to get across. So thank you very much, and I think I'm handing over to Jyoti now.
Thank you very much, Andrea. So thank you for all that I hear today. And as Andrea, I think with the presentation, the striking thing that really came to my attention was the numbers. So actually we're not looking at massive numbers, and actually not looking at massive numbers for the one that need to be screened. So I think that's the message that I want to try and get. But it's a group that sometimes just needs a different approach to getting them to come for screening. So just bear that thought in mind. So I was just going to talk to you about a bit about the QI approach and link that with the cancer DES. So my presentation is really looking at some of the barriers, some of the gap. Then I'm going to just talk a bit about personalization, a bit about capacity and best interest, and then link in with the DES with a couple of just suggestion and examples of what a PCN or a practice actually can do using the QI approach. So next slide, please. Thank you. So these are some of the drivers, and I didn't want to go into too much details, but just to let you know, really the common thread, the golden thread that's coming out of all the priority documents and the drivers, the the big people that are making all these decisions is prevention, whether it's prevention of cancer, it's prevention of diabetes or anything else. The big thing coming out is definitely, prevention, and cancer seems to be topping. So in public health, the early diagnoses and any outcome framework, and you've seen more and more work coming out in primary care through the QOF as well on prevention. So that's the key. And again, just put that thought and hold it for now. Just when you look at some of the other things, it will just come back to you. Next slide, please. So again, I just wanted to highlight some of the gaps that Andrea's already mentioned in terms of what LEDA has highlighted to us, but really some of the other gaps and some of the really strong statements that are pulled out of some of the papers are these, that actually you've got patients with LD that are dying 16 years younger than the general population, and 42% of them are from preventable and avoidable reasons, and delays being attributed to delays in diagnosis, treatment failure, and providing adequate care. And that amounts to about 1,000 people with LD dying prematurely with inadequate care. And we've already mentioned the gaps here. So again, not just LEDA, but all the other CPOL and all the other reports have showed that the failure to engage and provide the right treatment for that patient and make the adjustments, actually not just for cancer, but all other aspects of the care, has resulted on these avoidable deaths. So again, a really strong statement and a really strong thought that I want you to hold in your minds when you're seeing patients with LD. Thank you. Next slide, please. Okay, so again, I picked out some of the barriers, and again, Andrea alluded to some of them that came out through from the LEDA report, but I've just picked out and just divided into 3 separate areas. A lot of is some of my experiences, but some of them are evidence-based as well, but also feedback from the patients. So if you look at the person, again, it's about how are they accessing the appointment system? Are they getting the relevant reading material that would make sense to them? Are they able to access with mobility issues like the smears, etc.? Have we, is that the fear that they can't get on the couch and have things done? And is there a lack of understanding of why we're actually doing the screening? That goes back to the capacity point, but also the anxiety, the fear, and the embarrassment, because you're talking about doing a fecal sample. To some patients, and I've certainly come across the mild LD patients, that when you talk about feces, they all become shy and they don't want to talk about it. So you might just need to break that barrier somehow with them and the carers to start talking about it initially. So just really understanding from the person point of view, who are you dealing with? And on my first very slide, I've highlighted that that is actually it's the person you're dealing with. It's not the LDs, it's the person. So it's the personalization of care, really. So the health profession, again, a lot of the feedback that's come from the patients is the lack of awareness of how to make adjustments for LD. And I'm glad this actually a lot of the feedback, it's becoming less and less as I'm going to different forums, speaking to patients. So the awareness is we're getting there with the health professional, but not quite there. Of course, we've got time pressures. We've got patients now post-lockdown. We all GPs that are here, we understand with massive lists that are coming through, and then you've got a patient with LD that you need to spend a bit of time on, and you might feel pressured there. It's some of the attitudes of, again, this is a feedback from the or perception from the patients, is the attitude of the health professional, but also patients being seized from screening program. And again, I will talk about it in a minute about the capacity assessment and the best interest decisions. But that's what you would need to apply if you're going to seize people from the screening program. But also, the health professionals may themselves feel actually they don't have the skills or the resources through in the community to meet some of those needs for the patients with LD. Of course, moving on to the carers, again, I strongly feel if the carers understand the importance of whichever test, whatever screening, be it diabetes, cancer, then you have a better chance of engaging with the the patient, because obviously they know, the carer knows the patient, and vice versa really well. But also a lot of carers that I've come across, they believe that actually they've got LD, so they don't need to be screened. And that itself, again, takes a lot of breaking down of the barriers and making them understand why screening is important for everyone, really. And again, as I mentioned, not just the patient, but of the carers also find it embarrassing. A lot of the feedback that I'm getting from the carers is that actually when they go for some of the screening tests, there aren't any adjustments, and it's, you know, people are they aren't giving enough time, and people are watching the behavior. We just ask people to just mute themselves. That would be really helpful. Thank you. So there's just some feedback coming through from the patients that maybe the pathways that we've got aren't reasonably adjusted to meet the needs. So again, that's something for the system, and I'm really pleased we've already set that in motion for the breast screening, and we are looking now at bowel screening and making those reasonable adjustments on those calls and making sure people have had the time, etc. Is there any questions or comments so far? That or people feel that there are any other barriers? I'm happy to take some comments now. If not, then I can just move on. Okay, so no hands. I'm having difficulty seeing hands, so I could just move on and take questions at the end, maybe. Okay, next slide, please. Thanks, Harpreet. Again, I've just put this sort of concept, and we covered this in the previous webinars, the concept of personalization and reasonable adjustments. And again, just remember, with not just LD patients, with any patient that you see now, the personalized agenda is not just for LD patients. It's not, you know, one size doesn't fit all. You need to look at the patient and see how to fit the guidances around the patient. It's not that you're fitting the guidance on the patient, really. So it's about that adjustment that you make to anything for, or in your, you know, shared care, really, with any patient. And again, I've just used this example of Amanda, and Amanda is finding it difficult to process a lot of words. So actually, if you have an understanding of that, you as a clinician or the screener or the practice would ensure that you speak slowly, use very simple language, and give her time to understand and break down the sentences, and, you know, break down, and you give her very little information. So unless you know that, and that's what I mean by personalization. And I've given some examples here of using larger text and maybe arranging face-to-face, because some of them aren't IT savvy or don't understand, and it takes them some time to adjust to the new ways of working. And again, you know, things like you chasing DNA. So this was about personalization. If DNA'd an appointment, you know, rather than just filing the letter, just have a think about, is a patient with LD, why did they DNA? Did they understand? Where is the support that's required? Were they aware they actually had to go somewhere, or were they expecting a call? So just really understanding those barriers for some of them. And also just making sure that the invites are suitable. So if you are inviting them, a call quickly to say, hi, your, you know, smear test is due, please can you come on this date, probably may not work for everyone. So just make sure that you recognize as a practice, as a clinician, how would they actually understand the information that's given to them. And also, as I mentioned before, remember the barriers. You know, why is it they aren't engaging with some of the screening services? And again, this is, as I said, it's not just LD. You could apply that principle really to patients with dementia, or any patients really. It's that understanding, because there are lots of health beliefs and outcomes. And of course, the double and triple whammy if you've got a patient with LD from, you know, BAME group not coming up for screening. So we've got, you know, a complete inequalities in every area, you know, with that statement, really. Okay, next slide, please. Harpreet, thank you. Quick, really, I'm not doing a full-blown capacity assessment. We've got further webinars coming on capacity and best interest decisions, but it's just to say that actually, if you are offering screening and they're refusing, just do remember that it's your judgment as a clinician that has offered. It's their call to make that capacity assessment, and in that point of time, you're not saying they're not capable of doing anything, but it's for the relevant decision. And also you need to really understand, which I'm sure we all do at the moment, because we all have to sit through 2 hours of mental capacity modules as mandatory action every year. So I'm sure you understand that. But just a concept that I think you should bear in mind, that if you're saying and you're declining patients that they can't participate in the screening programs because they've refused, is that you've made that capacity assessment as the patient has actually refused, and that will be in their best interest. Next slide, please. And sometimes that that could be challenging. So if you yourself have problems, then seek help from senior people to make that best interest decision and really document it clearly. As I said, there will be future webinars coming to discuss a bit more in details about this, but I just want you to remember that actually it's your as clinicians, it's really your role to make the capacity and the best interest decision in relation to screening. You can get help from senior sort of local CLDT team, and Beauty is going to be here later to talk about that. And also there are sort of LD consultants that you can seek help from if you feel that you haven't been able to make that decision. So there is help there. Next slide, please. So this is the DES requirement, and whilst the document is actually not too big, it's about, I think, a 5-page document. The bit I pulled out for cancer really is in relation to screening. If I could just ask people to mute themselves, it'd be really helpful. I don't know if it's my computer doing that. I hope not. So the bit that I pulled out really is a DES requirement for cancer. So, and I've highlighted this, that you need to work with your local partners. So that would be the public health and also the Cancer Alliance. And you need one specific action to engage with a group with low participation locally. And this is where your data comes in handy, and which is where Andrea said, if you want your data, we've got practice dashboards now that we can share. So you can look at that as a PCN and decide, actually, you know, I've looked at it, and cancer screening in LD is an area that we're not doing too well and we need to improve on. And I've suggested some ideas here that you could actually focus on bowel, breast, cervical screening for LD based on that low participation and looking at your data. You could also further drill down and say, actually, I'm going to focus on all the LD patients with all screening types that have DNA'd the appointment. Or you could say, actually, I could look at all the LD patients with BAME, who are BAME, but also then DNA the appointment. So you could be as specific, as wide as you want, but it's for the PCN to look at the data and decide how they want to proceed. So this is just a DES requirement amongst the other things about safety netting and early diagnosis. I've just focused on one element. Next slide, please. Okay, so I just wanted to touch basically on what's available through the PCN and what perhaps the PCNs can think of, which I'm sure they have, and there's a lot more than I've put down here. But the additional role staff, particularly the PCPs, I've had examples of some of the PCP, the personalized care practitioners, that is, this is the health and wellbeing coaches, the social prescribers, and the link workers. They've done tremendous and excellent work with the vaccine hesitancy. And actually, it occurred to me, actually, if the patients are, you know, not turning up for the appointments or don't really understand the importance, perhaps we could train, and there are training offers through the local training hubs, to train some of these PCP workers to support that DES work. You know, if you're going to focus on the DNAs, then perhaps PCP workers could be trained to really have that engagement and start talking to patients to understand the barriers that we can then start breaking down. I've mentioned just now that the training hubs, the local training hubs are basically, you can say it's HEE on the ground. So Health Education England's arm on the ground within your, you know, local footprint. So it does all the workforce training and is meant to look at the requirements and needs of the additional roles. And part of that could be the PCP upskilling or training. Susan, I'll get back to you on the dashboards. And Andrea probably can answer that as well, but I'll get back to you. But there are data packs, and that was what I was coming down to. And we've got PCN data packs that can be drilled down. There's also some information on fingertips, which is a public health sort of England document. However, it's usually lagging behind a year or 18 months. So it doesn't really give you a really good up-to-date data as such, but there are some packs that the local cancer team is working on that we will share out with the PCNs, and that would be a good base for you to look at your data and see what you want to do in terms of the QI. There's also support from the CLDT team. Now I'm working with the local LD teams and also the cancer teams to try and pilot a MDT model around some of those challenging patients that you feel, not just for screening, but other areas as well. So almost having like an ICM type model where the CLDT teams can come and support and see and understand what support's needed, and, you know, and just work as a multi-professional team really supporting the patient. And of course, there's a great big opportunities during annual health checks. So again, if you feel that or know that the patient is coming up to that screening age, ensure that you gain consent about sharing the information with the screening services, because as I mentioned, now we've got breast screening that have got a reasonably adjusted pathway. So these patients are getting calls and from trained people, and they're given more time, and they have more resources to try and get them to understand about breast screening. There's lots of videos, lots of resources which are LD friendly. So if you know that, just and you need to then let the screening people know, or put an alert on your practice system to say that they've got LD. So when the data is seen from the other side, the screener is aware of the LD status. So just make sure you get that consent. Although at the moment it looks like all the everything will be drawn out by everyone, but yeah, that's the opportunity of health promotion as well. I've known PCNs that are now doing the health checks with the PCP workers. So that then draws out the issues of, are they obese, have they got diabetes, what else can they do aside from screening. So just bear that in mind, that if you've got a PCP worker, then try and engage them in some of the annual health checks. So next slide, please.
Sorry, Jyoti, we've got questions for you.
So let me, if I just finish that and then I'll come to the question. Is that okay?
Yeah, that's fine.
Thank you, Bolo. Thank you very much. So I just really quickly wanted to check on the just talk to you about the QI approach here now. So again, I've just used some examples. So again, as I mentioned, you will have your data packs. If you look at the data pack and you find actually a bowel screening is an area that we're really not doing well on, you then decide to do that. So you need to set a very, very clear aim with a timeline and a percentage. And I've put a hypothetical aim here for you, which is increasing bowel screening in LD patients. You specify the patient population by 10%, it could be 1%, 2% over the next 6 months. So you need to be really specific with the aims, and you need to understand how you're going to do it. You're going to do monthly searches. How are you going to outcome or check that? So monthly searches, or looking at the data packs again. And the change ideas are basically done as a PDSA cycle, and the results are seen in a run chart. This is the basic QI approach, and it's slightly different for the audit, because in an audit you see a snapshot, whereas a QI approach you'll be testing different ideas and accepting and rejecting the ideas that don't work. You reject them, and the ideas that work you then embed them, and that will just ensure that you are going to sustain the changes. So if you decide that actually it's on the next slide. If you just move on to the next slide, please, Bola or Harpreet. So again, I've just put some other thoughts here. So it's, if you look at your 3 cancer screening uptakes and you define the aims, you decide who the team is going to be. So who's going to be the lead, the overarching lead, and who's going to make the phone calls, who's going to send the text, if that's the approach you're taking. So you really need to be clear. You need to then look at the balancing measures. So are the people that are at part of your team, if they focus on this work, would they be neglecting the other work? So you need to balance that. You just so I increase the screening, and actually all the diabetics are have gone out of the window. So it's just make sure that that balances out. And then you run the PDSA cycle, and PDSA cycle essentially are change ideas. So if you decide that you're going to see how calling patients by a trained screener helps increase the uptake. So you then basically measure that. Has that idea worked? And if you see actually, yes, it has, then you embed that. If you see actually, no, it made no difference at all, then you discuss as a team, can you modify that idea, or do you want to reject it? So that's a team discussion. And if you feel that it's rejected, you cannot modify it anymore, that's fine. Let's move on to the next one, next idea. So that's what we mean by, the cycles. You plan, do, study, and see what the results are. And then you put those results, or you review those results on run charts. So I'm just mentioning this to you because the expectation, and it's a really brief QI sort of a slide on something that I think it took me almost 6 months to learn, but it's a really brief thing, and I just wanted to mention that because the expectation is sustained work using QI approach at a PCN level. Next slide, please. So just some of the change ideas I've mentioned here are that you could train the care home staff, so the LD care home staff, on using the kits. You could send the videos to the carers, and there are specific video resources, and I'm going to share it on the next slide. The virtual group consultations for the carers, and that could be run by your PCP, the health and well-being coaches, or the link workers, about how to do bowel screening, for example. You could use some scripts, and there are some scripts that are as a resource that are available for your practice staff to call patients and to say the right things, essentially. And of course, I've mentioned about health and well-being intervention to the health and well-being coaches, if you're lucky enough to have those. And of course, there are some relevant patient leaflets that you could send out and see what the response, and run that PDSA cycle. So I've just put some change ideas that we've been considering in our sort of in our PCN, I would say. But it's just something that and I'm sure there'll be a lot more there, but just some of the ideas. Just next slide, please, and then just take some questions there. Next slide, please. Okay, so I put some resources, and when you open these up, there are videos, there are patient-friendly leaflets on these, and it's worth just keeping those. This slide particularly, or accessing this slide just to get those templates out. It's really, really useful things for LD patients. So just hold on to those. There's also a NEL website which Harpreet is going to talk to you about at the end. So I'm going to stop there. So I really ran fast through, and I'm going to let's go through. Bola, do you want to just tell?
With me, yes, the question was from one of the delegates. Let me just read that out to you. It says, how do we get access to these dashboards, please?
Oh, I think we've lost Jyoti, haven't we?
Yes, I think we have, because she was muffling towards the end.
Yeah. So I think
let's do it at the end.
Okay, she's here now.
For BHR, I would be contacting Mark Lockwood and maybe the LD commissioners. Now, I have the names of those commissioners, but if it's okay with everybody, maybe we can just double check with the commissioners, so we don't make sure that they've got a heads up prior to giving out their email addresses to contact for obtaining those dashboards, which are produced by KEG, by the way. So they extract on a monthly basis. So you can see that steady increase as you sort of engage with more people with learning disabilities, and the numbers increase. So it's actually a really good way of monitoring the increase in uptake. So if that's okay with everybody, I'll double check what's happening with the I'll double check with the commissioners to ensure that they're happy for their email addresses to go out for contacting around the dashboards.
Thank you, Andrea.
Thank you.
So
because we might be able to, I'm just thinking off the top of my head, we might be able to actually put a link on the resources so that people could go directly to those dashboards, and that actually might be a simpler way of doing it. We'll just see whether that's possible first before we go down that route.
That's fine, Andrea. But the plan is actually to share to the PCN level anyway. So I think eventually it'll come down. I had a brief look actually before this webinar to see if there was anything on the KEG template searches on EMIS, but I couldn't find anything. It might just be that I'm not in the right place.
But the data looks very similar to the data that's that I presented on those earlier slides. So you actually see your numbers. I know it was aggregated by CCG level, but you can then see those similar numbers and also the general population by each of the screening programs. So it's really useful, and it also has the annual health check numbers. So this is very useful to PCNs as well.
Yeah, that's great. Thanks, Andrea. So I do agree, Andrea, that I think that's probably the basic thing really for any PCN to reflect on the data and then to start working on the QI plans. Okay. So I'm sorry, I was really going fast. I'm just aware of the time. So I'm going to pass it on to Beauty, who is a wonderful nurse from the CLDT team in Redbridge. Beauty, on to you. Thank you.
Hello, can you hear me clearly? Okay. Thank you. I'm so impressed. We've never had such support from CCG and from the GPs. The way you are actually focusing on awareness of learning disabilities and actually doing QI projects to enable people with learning disabilities to access health services. I'm really, really so pleased with the work you are doing. So I'm here to, most of the things you've actually mentioned, that's why I'm quite impressed with all the information about learning disabilities, providing reasonable adjustments, training, all that has been captured in what you've been presenting about cancer screening. So my emphasis today is that the learning disabilities team across the 4 boroughs, we are here to support you. And we've got the social workers. You find that sometimes you might need additional support to enable the client to access the services, like maybe one-to-one support. So they are there to assess and provide that support. And we've got psychiatrists who would also help for people who are anxious to access those services. So to look at how do you manage the anxiety? Could you, okay, how do you manage the anxiety? And we've got psychologists as well, and OTs and physiotherapists, and then our learning disability nurses. So, and importantly as well, we've got speech and language therapists within the team. So what I also want to emphasize is within our services, when someone needs that kind of support to access the mainstream services for cancer screening or breast awareness screening, we have a referral process. Please refer the individual in good time so that we are able to support them. And also, even when you are referring, follow up with communication with us to ensure that we capture that referral in good time, because sometimes a referral is made and then you capture it when it's a bit too late. So when someone needs to go for screening and they have DNA'd and you want support from the learning disabilities team, please make a referral in good time so that we can actually work with you. So we can only work with those individuals that are referred to the service. So the role of our learning disabilities, what we do is we support people with learning disabilities within health promotion. The learning disabilities nurses, they actually carry out health assessments. Through that health assessment, they identify health needs that they can work along together with the GP to make sure that the needs of people with learning disabilities are met. So we also provide support to the communication needs of people with learning disabilities, and including other health services to communicate effectively. So with communication, it's important to get the clients to understand the identified health needs. You have to provide the easy read information. So when you are trying to explain to the clients, we also have speech and language therapists who could support with enabling the client to understand what the procedure is and how they could go there. We've had clients, we've got like phobias of attending hospitals, and we've done desensitization with them to actually enable them to access mammograms, to access the other bowel cancer screening process, because it's quite a long process. And using visual information, showing bowel pressure machines, telling them what you are planning to do, giving more time to process information, and seeing the person, not the learning disabilities. I think in the previous slides, we were talking about support for develop new ways of working with, deliver better care for people with learning disabilities. It's about working as an MDT. So when you have a client who is complex, please invite us to the MDT. And I think we have Coordinate My Care on, which has been introduced so that all the MDT can access that. So we need to make sure that if there's a complex case, we are all on board together, the GPs, all the professionals involved, we are working together. And actually, it's actually doable. I've carried out MDT meetings since last year. I've been working very closely with GPs. So there is a big improvement in how we are actually working together to meet the needs of people with learning disabilities. Okay, the next slide. help facilitation. So for our clients who need access to mainstream services, we can also facilitate the process of going into the hospital. We've got the hospital liaison nurses who can actually help with that. They are available, and I can email you the links to the liaison nurses, because that's really, really important that people with learning disabilities, they can access the services that they need. And we can also liaise with the care homes to find out who is the health facilitator within the care homes, and also link with us so that it's an MDT approach. And communication support, we've mentioned that. Supporting GPs, when we carry out our health assessment, the first action plan we normally say is access for annual health checks, to make sure that the person has got an annual health check. And that annual health check with the health assessment, it can identify whether the person has had a bowel cancer screening, breast cancer screening. So if they haven't, we actually then link with the GP as part of the annual health check to make sure that those things are met. So the health assessment that is done, the annual health check, we need also to make sure that the health needs that have been identified in the annual health checks, they are being met. So if you identify those health needs, please, when you do your health action plan, link with us, link with the carer, link with the service user. They actually would understand their own health action plan. Give them a copy of the health action plan so that they know what to do. So create links with the health professionals, and patients should keep their own health action plans as well. And it's good to actually, when they come for reviews, to review the health action plan to see how it's going, working with the multidisciplinary team to see how the health action plan is going, liaising with the health facilitator as well. So support with bowel cancer screening. We've got a lot of accessible information that we can provide with staff. There's Easy Read. If you go on www.easyhealth.org, has got some bowel cancer screening Easy Read information. I can email them to you as well, some of the information I have, which are easily accessible for people with learning disabilities. So sexual health supports we do provide, because when we are talking about screening, we then talk about the support following screening that can affect the sexual health of people with learning disabilities. And we also facilitate to enable them to access the health services required under sexual health. And support with attend scans and x-rays and MRI scans, we actually would do for those clients who have difficult accessing, or we have phobias of these big machines. We can actually do a desensitization process, a care plan on how they could actually go into an MRI scan, or how they could go into the CT scan. So it can be an MDT approach, and we actually get the client to go and visit until they get used to that MRI scan, and then they can hopefully, with support from psychiatry, if they need some sedation or some support, then it's an MDT approach. So diagnosing overshadowing, it's a very sensitive area where sometimes because of for our clients who have got like ADHD or autism, and when they are presenting with behavior problems, we can just assume that it's their behavior because their diagnosis is autism, or their diagnosis is ADHD. So that can overshadow an underlying health issue. So when a client is presenting with behavior problems, it means that they actually need support. They need further investigation. They actually need physical health to rule out all the underlying health issues. Consent and capacity is actually a very, very complex area where we are now working very well with GPs. You know, with our clients, most of them, they haven't got capacity, and sometimes it's difficult for them to consent. So we might need an MDT approach and best interest approach to deal with that. So under the Mental Health Act, we know that adults should be assumed to be competent. So if we don't carry out an assessment for them to make sure that they have capacity, at that very moment, we assume that they have capacity. So therefore, what we need to do is to assess their capacity if we feel that they lack capacity. And the patients that are competent to make their decision, we should respect their decisions. But those that are not, then as an MDT, we have a best interest decision or best interest discussion around it. So patients need sufficient information around consent and capacity. And usually you would use easy read information, work with the speech and language therapist, work with people that know the client better to actually gather information around whether the patient can understand. So we all know that no one can give consent on behalf of an incompetent adult. So therefore, what do? We have to have a best interest meeting. So any decision has to come out as a best interest decision. So relatives, carers, and friends should be consulted as well. But however, that decision should be an MDT decision. And I know the 4 areas we look at whether they understand information that is relevant to the decision, whether they can retain the information long enough to make the decision, whether they can use or weigh the information benefits or risks, and then whether they can communicate their decision. So those are the only 4 areas we focus on. So providing health intervention and specialist support is to promote independence. This is really crucial. That's where you can refer to OT or nursing to actually, especially if someone has had a procedure, they want to get back to promote independence. We need to get involved the learning disabilities team at an early stage so that we promote their independence. So we can share expertise, including training, advice, and practical support for learning disabilities and families and carers and other agencies. So it's about MDT, MDT working together as a team to enable clients to access health services. But what I'm actually saying is we are here as the learning disabilities team, and referrals, please, if you could make referrals, follow the process for making a referral. Thank you.
Thank you, Beauty.
Thank you. There is a question for you, Beauty.
Thank you, Beauty.
Okay.
Yeah, the question is there a standard referral letter for the practices to use?
Yes, we have standard. Each borough has got a referral process, and for Redbridge, we have we refer via the, the first contact team. You get that link online. However, there are clients who may actually be known to a SIM team already, or may have been known to, if they are known to a social worker or a nurse, and you actually know their work. So all you do is you communicate with them about the problem. But if they are not known to us, then you have to make a referral, follow the process. So do you want me to email the referral process to you?
That would be nice. That would be nice. I'll drop you an email to see if I can have that, so that I can share that with all the delegates that attended today's session. Thank you very much, Beauty.
But I think an MDT approach, even you can invite us to a link. We are inviting GPs a lot to our MDT meeting. Yesterday, I was so pleased. On Monday, I just sent an invite to one of the practices using the discharge link, and then the practice manager attended the meeting, which was really good. Thank you.
Thank you for that. That was a really great session and a lot of really useful information.
Thanks.
What I want to do is I just want to quickly share the web page with you. So what we've done in North East London is we've made a really big push to kind of get a learning disability and autism page up on the new CCG website. So I will get this link sent out as well with the slides. But if you go onto the North East London, the new North East London CCG site, and you go to your help banner at the top, and I can't scroll down, but you'll find that there's a section at the bottom called Learning Disabilities and Autism. And when you click on that, it will come up with, just show you actually. Can everyone see it properly?
Yes, we can.
Yes, we can.
It doesn't want to. Okay, great. Doesn't want to work for me, does it?
We can see cancer screening.
Yeah, I just want to go back to the main page. So when you click on the tab, it will come up with this page, and it will show you kind of like some information about learning disabilities and autism with some really good links. And then it's like, oh my god, it just keeps going through, really delayed. It's got tabs on the side of the different kind of work streams going on at the moment. So you've got LEDA, annual health check, STOMP, cancer screening, positive behaviour support, and care and treatment reviews. So if you click on cancer screening, what we've done is we've kept the language very simple so that families as well can use this page. And we've got a link here. I won't open it because it might not open properly. But if people click on this link here, local borough community disabilities team, this gives all the contact details for all the 7 boroughs and the community teams, and gives links to the web pages, which will then explain how you can make referrals. And then what we've done is we've outlined the 3 different screening programs, and we've put all the links in one place, because I know it can be a pain, especially when you're working with a patient and have to look at different websites to get different links. So what I've tried to do is keep everything relevant on one page, so that all you should need to do is go onto this one page and all the links, easy read documents, different videos, guides about colonoscopies, guides for carers are all in one place. So hopefully you'll find this a bit more useful. So there's information about bowel screening, breast screening, and then cervical screening as well. And every time, like Cancer Alliance, they're working on a lot of animated videos. So I'm working with Ford, who's the comms lead for Cancer Alliance as well. So he'll send me videos over. The plan is to kind of make a big push for this page as well. So I should be meeting with Ford soon, and we've got a comms plan. And what I would like to do is get this out more publicly. So as well as obviously sending this out to all the GPs, we're planning to get this out to as many parents and carers as well, different providers and things like that, so that, you know, this is all useful information that they can use to help support people as well. So that's it on the website. So we've got another 5 minutes, so if anyone's got any questions for the panel. I don't know if people can put their hands up on Zoom.
I just wanted to add one thing, really. It's just to say that there is support available for training your staff, albeit, you know, if it's practice staff or PCN staff via the training hubs to do a bit of cancer training. We've linked up with CR UK as well to try and support some of that training, not just for sort of admin clerical roles, but also for other clinicians and any new people that have joined the PCNs or practices. So do get in touch with me if you feel that as a PCN, as a practice, you could do with some update and training. We could arrange that for you.
Thank you. I think that's it. I don't think we've got any other questions in the chat either. No. So if you do have any questions for anyone.
Sorry.
Sorry.
I was going to say, normally Amrish has some excellent questions. Amrish? I don't know if he's still here. You normally ask good questions. Okay.
What I'm going to do is I've popped the LD and autism team email in the chat box. So if you have any questions for anyone regarding this, you can always send it over to us, and then you know, I can Dr. Sood or Beauty or Andrea as well. And like I said, the slide will come out to you all, and a link to the page as well. And Masuma's just put something in that, yeah, there's a reminder that there's a learning disabilities and autism webinar tomorrow as well. What time is it, Masuma? Is it 1 to 2 again?